Welcome to the second in a series of 3 panel discussions between Pfizer and Sage on issues that impact LGBT older adults. This afternoon, we will focus on the Affordable Care Act, what it is, how it is shaping up to look, and how do we think it will impact the LGBT community, and specifically LGBT elders. As Ken said, my name is Catherine Thurston, and I'm Sage's Senior Director for Programs. I'm very pleased to be moderating this afternoon's panel with some of the most expert voices in the field of healthcare policy, direct healthcare service, and LGBT health advocacy. Sage is also honored to partner with Pfizer and to promote Pfizer's Get Old campaign and the philosophy that aging is not in and of itself a disability. I'm also pleased to see Sage stakeholders here at Pfizer headquarters and to welcome some of our Sage affiliates and constituents from across the country that are joining us via the wonders of technology. For those of you who don't know, Sage is the nation's oldest and largest organization devoted to improving the lives of LGBT older adults through direct service, through policy advocacy, and through training and technical assistance, both in the aging network across the country and in the LGBT community. This afternoon's topic of the Affordable Care Act focuses on all the points of our mission. We will explore together the Affordable Care Act as it impacts healthcare policy, its delivery, and maybe most importantly, its potential impact on us as individuals, as LGBT people, and as older adults. With that, I'd like to introduce our panelists this afternoon, and then I will be posing a series of questions to them. We'll have ample time for Q&A from the audience, both in person and our virtual audience, so I ask that you hold on to your questions until we move to that portion of the panel. Joining us today are Raul Damas, Joe Baker, and Jay Laudato. Raul is the Senior Director of U.S. Policy at Pfizer, where he leads the development of policy initiatives that advance public health alongside Pfizer's commercial objectives. He is an experienced public affairs professional with a background that includes public policy, lobbying, grassroots advocacy, public relations, and political campaigns. Joe Baker is the president of the Medicare Rights Center and has been since June 2009. Joe is a member of the Institute of Medicine's Board of Healthcare Services and Committee on Geographic Variation of Healthcare Spending and Promotion of High-Value Care. I hope those meetings are a little shorter than the actual title of that committee.
Yeah. It's over, frankly, now.
Well, he was. He also serves on the U.S. Department of Health and Human Services Centers for Medicare and Medicaid Services Advisory Panel on Outreach and Education. And maybe most relevant for this afternoon, he's an adjunct professor at the NYU School of Law, where he teaches a class on the implementation of the Affordable Care Act, which means if we have questions that no one else can answer, we will ask Joe those questions.
Do my best.
Jay Laudato is the executive director of the Callen-Lorde Community Health Center, which is New York City's largest LGBT-focused health center. Jay has over 30 years of nonprofit healthcare administration experience and is in his second tenure as the ED of Callen-Lorde. Prior to this, Jay held the positions of Director of Managed Care and Assistant Director in the Division of Financial Planning and Policy at the New York State Department of Health. So as you can see, we have 3 of the most esteemed panelists we could probably ask for today's discussion. And I'm going to open up the panel with a question for you, Raul. Many people are still confused about what the Affordable Care Act is and how it will affect them. Perhaps you can provide an overview on the Act and some general points about how it is currently shaping up to look.
You bet. Thank you very much, and thank you for this opportunity to join you this afternoon. It's a real treat for me in my role, and I think you guys will agree. Given all of the work that we regularly do in our respective positions on the Affordable Care Act, finding a room full of individuals who on a spring day are willing to come in and spend an hour hearing about the details of the law is a rare event. So I'm thrilled to be able to share some thoughts with you, and I'll ask my fellow panelists to offer their thoughts because even though this law was signed into law in March of 2010, we've been working on understanding it and helping influence its implementation since that time. We're not even at the point where its key provisions have gone into effect. That's set to happen in January of 2014. So I worked in Washington long enough to pick up some Southernisms, and even though I'm a New Yorker, and you ain't seen nothing yet. I think this law is extremely complex. It hits a number of stakeholders. I'll focus on a couple of areas where I think it's particularly relevant to you and the members of the LGBT community. But I'll start off by offering just kind of a couple of high-level views of the goals of the law, and then I'll talk very quickly about how I think they're going. The goals of the law, and this is, I think, an uncontestable point, regardless of which side of the political spectrum or which side of the vote you were on if you were in Congress, was to increase the coverage of Americans, to improve the quality of the health care delivered in this country, and to reduce the cost and reduce the spending on health care in this country. And I would say that the jury remains out on most of those provisions, again, not just because its implementation was meant to take a period of time, but also because the goals are extraordinarily ambitious. I believe we will be very pleasantly surprised in 2014 when we see a good rate of adoption of the Medicaid expansion. I know that there were a lot of concerns about that following the Supreme Court's ruling. I think you're seeing a number of the states that had said, hell no, we're not going to participate, rethinking that decision and recognizing that expanding coverage to those populations is important and not incidentally politically important for them to do. I would say with regard to the exchanges, I think you'll also see a lot of the insurers who are concerned right now about the viability of these new insurance markets, very eager to participate in those commercial marketplaces and providing good, meaningful coverage reflective of the spirit of the law, and I'm sure we'll get into all the details of that. With regard to improving the quality of care, that is really an extraordinary. I've been in healthcare policy for a relatively short time in my career, but I'm always amazed at the fact that we're now having a discussion in this system about things like quality. It really shows how far we have to go to be, and I know the term and its measures have been around for an extended period of time, but it's kind of like the way that the term accountability is used in education policy circles. It really is a representative of a breakthrough moment where people say, enough is enough, we really need to improve this system. And I think there are any number of measures that have been put into place to improve quality, but I would say it's still too soon to tell whether you're going to see the ingrained habits that have over time reduced the level of quality in healthcare, or at the very least reduce the incentives to produce high quality healthcare, really change. And then finally, with regard to lowering the cost, the pharmaceutical industry has participated in the support of the Affordable Care Act's passage via the provision of a number of discounts and rebates. But overall, I think it's really up to the functioning of the exchanges and the movement of people into real meaningful coverage away from the emergency rooms and other drivers of the care in the system, of cost in the system, that are really going to make the meaningful changes in terms of lowering the rate of spending on healthcare in this country. And again, I think it's a little bit too early for us to tell. Again, this is a function of the goals of this law being extraordinarily ambitious, implemented over an extended period of time, and you have a number of differentially motivated stakeholders kind of waiting to see what the other one does before they themselves commit. But I think it's still a tremendous opportunity for the country as a whole to seize the moment, use the law, and drive forth some meaningful changes that are going to have tremendous impact for any number of communities, but most certainly the LGBT community. And I think I'm going to stop there and let you guys kind of flesh out the rest, because anyone could speak for an hour on this thing and only cover the tip of the iceberg. So please, I'd love to hear your thoughts.
So maybe I'll start with the second question that's actually for Joe and
Mm-hmm.
expand a little bit, Raul, on the last point that you made around the different stakeholders and how they're affected by the Affordable Care Act. And so there are various categories of folks that are affected differently, those under 65, non-Medicaid eligible, et cetera, who will be affected in different ways as the law unfolds in terms of eligibility and coverage. Joe, maybe you can help us understand those populations a little better and how they'll be affected.
Sure. So, the main goal of the law, as said, is to get people health insurance coverage. And there are a variety of things as well that we'll talk about, but that is the main goal. So who in this country is without health insurance? Primarily poorer folks. Folks under 400% of federal poverty, and that's going to be covered both by Medicaid and by the marketplace plans. So let me just take the populations and kind of divvy them up. So I'll start with the folks that are poor. And so the law changes and nationalizes, if you will, a Medicaid eligibility screen for people at 138% of federal poverty or less. Okay, so before every state had, if you had one state's program for Medicaid, you had one state program for Medicaid. There's 50 different Medicaid programs. Now there will basically be one, with the caveat, with the warning that, of course, with the Supreme Court ruling, not all the states are taking up this Medicaid expansion. Here in New York we will have it. California will have it. As was said, there are more and more states are now coming forward. Arkansas recently decided to do it with private plans. But the large point here, and it is state specific. Many of the southern states aren't doing it. Texas, Florida, etc. Question whether they will in 2015 or 2016. But for 2014, even if they got their act together, it probably couldn't come online now, although some of them may be able to. But for folks up to 138% of federal poverty for a single person, and then it's higher, of course, for the number is about 11,000 12,000 for a single individual, and then higher for larger family sizes. You're going to be eligible for Medicaid, and you're not going to have to worry about your assets. They're not going to look at your bank account, all of those kinds of things. And it's a much, much more simplified eligibility screen. You don't have to fill out one of these, crazy long things, go down to the DSS office or, some government office. You can do it online. It's going to be, it's promoted to be very easy. We'll, of course, see, but that's for people with Medicaid. Above 138% of federal poverty, you're going to be eligible if you don't have insurance. Of course, if you already have insurance through an employer or through other individual coverage, you can keep it. But if you don't have insurance and you want a subsidy to help purchase the insurance, because there's two things that are going to be available for folks between 138% of federal poverty up to 400% of federal poverty. Okay? And that is subsidies to purchase a plan in the exchange. You can only get the subsidies to purchase a plan within the exchange. If you're under age 30, you also have other plans that you can buy, which are catastrophic plans. The plans that you can buy in the exchange, there's 4 of them. There's gold, silver, platinum, gold, bronze, and silver. I didn't do that in the right order. There's no tin. Bronze is the least generous plan, which would cover actuarially, generally about 60% of your health care costs. The platinum plan covers 90% of your health care costs. The subsidies actually are interestingly done. What they basically do is they don't say, we're going to give you $10 or we're going to give you $3,000. They basically say, depending on what band you're in, whether you're in 138 to 200% of federal poverty, 200 to 300%, or 300% to 4%, you only have to pay a certain percentage of your income, and the rest of it is subsidized, the rest of your premium is subsidized by the federal government. And we can talk more in detail about that. And it's all going to work through our favorite agency, the IRS. It's all going to be done, which is coming under lots of attack lately. So, and healthcare is being, brought into that equation, unfortunately. But in any case, you're going to get a tax credit, basically, up front. in the form of these premiums. And then if you're at lower income levels, you're also going to have decreased cost sharing. So that make it simple, rather than paying $20 for a copayment at the doctor, you might only have to pay $5. So it's really making that insurance affordable for folks. And the question will be, combination of the subsidy and what people pay out of the pocket. Will it really be, affordable over the long term, or even as we roll this out? But the hope is, of course, that it will be. Then you've got a whole host of people. What do we do with the people over age 65? Well, we've got Medicare. And Medicare is not significantly altered by the Affordable Care Act. A couple things are happening. One is the closure of the donut hole. That's that gap in the Part D prescription drug coverage. And the pharmaceutical industry and government stepped in, and they're closing that donut hole with discounts and through other means, so that it will be gone completely by 2020. And so that's one thing. The second thing, there's a lot of what we call delivery system reform in Medicare going on. And one piece of that is you might read about hospitals forming what are called accountable care organizations. We can talk a little bit more about that, but that's hopefully going to bend the cost curve. The good thing for beneficiaries or patients there is that they'll hopefully, the whole thought is we'll have better coordinated care. Your doctor will talk to the lab, he'll talk to the home care agency, he'll talk to the hospital. There'll be what we like to call warm handoffs, which Jay does in his shop, but not everybody does, And then I think the other thing, with Medicare is a variety of benefit improvements, like preventive care being covered with no copay up front. So you need a colonoscopy, you get it. There's a wellness visit for the first time in Medicare. The one thing that I'll mention, and then we can move on and we can talk about these things in more detail, for folks over 65 who are also low income, right? You remember I said Medicaid has been expanded up to 138% of federal poverty. It has not been expanded for folks over 65. It's still limited to 100% of federal poverty in most states. And so that means that if you're 64 and you're on Medicaid and you're at 125% of federal poverty, you're going to kind of fall off a cliff. You're going to go into Medicare, just Medicare. And Medicare has a lot of cost sharing in it. If you're on Medicare, you have a Medigap policy, or you might have a Medicare Advantage plan to fill in the gap. So that's going to be an issue, I think, for some folks. And we're focused on that issue and starting to talk to folks about that. So I think that is, I think, a gap that is going to occur. The other thing is, of course, long-term care. And the Affordable Care Act did have a provision that would have developed a long-term care subsidy, if you will, or program for folks, people that had not already turned 65. And that was repealed. That was one part of the Affordable Care Act that's been repealed. So not a lot of long-term care, and we can talk a little bit about that. But those are kind of the buckets of people and how they're going to be addressed in the Affordable Care Act.
Thank you, Joe. I have to say, for those of you who haven't listened to a lot of stuff about the Affordable Care Act, this was one of the most succinct and clear 5-minute or less demonstrations.
Well, you
of that.
gloss over a lot of the details. You can get it done quickly.
It's really terrific. I want to ask my next question of Jay, and I want to drill down a little bit and talk specifically about the LGBT community. So, Jay, while many details of the Affordable Care Act are still, as we are hearing, unclear, Callen-Lorde, as part of Healthcare for All New York, has done some advocacy work in this area. So what can you tell us about the Affordable Care Act and how it's going to affect LGBT? Maybe look at the T a little bit separately from there, and those with HIV or AIDS.
Sure. So Callen-Lorde is a community health center, and we provide care regardless of ability to pay. And so we have many people who are uninsured who come to us. And what's very clear is that LGBT people are more likely to be unemployed, are more likely to be poor. And if you're a person of color, it's impacted even more. And it gets worse, actually, with age. Employment, which is how we derive health care up until this point, is more and more tenuous as people age. And it happens as a double whammy, because while everyone should be getting preventive health care their entire life, it's when you turn 50, when you turn 60, that issues of chronic illness begin to really emerge for us. And you need and consume more health care as you age. And yet, it's this time when, for many in our community, they lose their income, they lose their jobs, and it's a very vulnerable time until the safety net, the true safety net of Medicare appears for folks. And so we're very concerned about this. We're obviously delighted that in New York, Medicaid eligibility, as Joe said, is going to go up to 138% of federal poverty, which, just so you guys know, is about $12,000 a year. So it's not a huge amount of money. And that, in the exchange, people will be able to purchase plans. But I will say, I have been looking at the plans and looking at the cost sharing, and it's a fair amount of money out of pocket. Some of the plans could really cost someone at, say, $20,000 a year in income, about $3,000 all in, less. That's not the entire premium, but that's your cost sharing. And so for some of our folks who are very vulnerable and are living at very low incomes, there's a lot we don't know. But there's two areas in particular at Callen-Lorde that we're particularly concerned about. The first is people living with HIV. New York has really had, has been a tremendous leader. People in New York, whether they're insured or uninsured, whether they're an undocumented person, not legally residing in the United States, are eligible for ADAP. And ADAP basically covers essential medications and essential medical services. And for people with health insurance, it will wrap around their insurance and covering their deductibles and copays and even their health insurance premiums. Under the ACA, what we don't know is how ADAP as a federal program, the AIDS Drug Assistance Program, is going to continue under the ACA. Will ADAP continue to be there, as the federal government really will begin to look at pulling back some of these subsidy programs that have been intended for the uninsured throughout the nation as we gain insurance eligibility? Certainly, I think people will be probably more responsible for co-pays for medications. And again, as Joe told you about the plan types, your out-of-pocket expense, if you pick the lowest one, could be 60%, would only cover about 60%. So there's some real concerns there. I actually believe that New York State, which adds a lot of its own tax levy to the ADAP program, will continue with state dollars to subsidize people living with HIV, but it's really unclear. And we've not had guidance from New York State. The other area that we find that is most uncovered and is specific to the LGBT community is transgender persons. Because, our other health conditions are common to everyone else, but HIV is of a higher prevalence, and people of transgender experience have needs for healthcare needs that have not been anticipated at the federal level. New York State did a great thing in requiring that all plans accept persons of transgender experience into plans through the benefit exchange. However, it did not say you have to pay for these benefits. And in fact, from what we see and from the model plan that was selected, transgender health benefits are not included under the exchange. This is disappointing, but it's not terribly different than the current state of affairs. We hope that we can advocate, and we hope that New York State as a regulator and government as a regulator of these plans will hear community input, whether it's on issues like HIV, or issues of transgender health, and step up and ensure these requirements are put into the plans.
Thank you. Thanks a lot, Jay. So this question is for each of the panel to answer in turn. And I think as the Affordable Care Act is going to roll out over the next year to 10 years, what it sounds like, many of us will have more questions. How are your organizations preparing to deal with questions from your specific constituencies? Raul, why don't we start with you?
That's a great question. So Pfizer has a long-standing program called Pfizer Helpful Answers. It's a patient assistance program that provides medicines, Pfizer medicines, although I should mention that almost all of the large pharmaceutical companies have similar patient assistance programs. It provides medicines, in our case Pfizer medicines, at no cost or at greatly discounted cost to everyone from the completely uninsured to the underinsured, to those who are insured but are also looking for some type of reimbursement assistance. And then different types of drugs, certainly oncologics, oncology medicines, have different types of patient assistance programs, even just for that product specifically, catering to the different sites of care at which patients are administered those drugs. Over the past, 5 years, over 3 million patients have availed themselves of these services. And you might say, well, what happens once the ACA goes fully into effect? We have the coverage expansions, and there's no more uninsured. That's actually not going to be the case. The number of the uninsured that will remain will fluctuate, and anyone who tells you they know it exactly, even if it's the Congressional Budget Office, is regularly adjusting its projections. But we'll have several million Americans, over 10 certainly, and the numbers go up to about 20 million, who will remain uninsured for any number of reasons. They fall into some of the gaps that we've been talking about with regard to where the Medicaid eligibility levels go. Some of them will be in a difficult spot because their employers decide not to provide the insurance. And many of them will simply choose not to purchase the insurance. I think all of the economic and coverage models that either industry or government or the non-governmental organizations are using show that that is probably going to be a certain segment of the population. So for all of those types of individuals, the Pfizer Helpful Answers programs, and again, the patient assistance programs that any number of the drug companies have, will be available to them to help them with pretty much any type of the products that we offer.
Great. I think then it's a very good point that not everyone will be in all the modeling that we're doing, even in Massachusetts, which of course has Romney Care, has implemented this kind of health reform. Not every person in Massachusetts has health insurance, either because they don't want it, they don't sign up for it, or if they're in this proposal, one of the large groups of folks that will not be eligible for coverage under the exchange or marketplace plans are undocumented immigrants. So there will continue to be, folks showing up at emergency rooms and at Callen-Lorde and other places without insurance. And so a lot of the programs that we do still have will need to continue, as Jay's saying, and here at Pfizer as well. And then I think we'll be looking at whether or not they're sized correctly for the population, and hopefully as, when anything rolls out, you have what's called a take-up rate, and the take-up rate would hopefully increase through the years because, there might be some hiccups, some problems. There certainly will be in the beginning. Folks might want to wait and see how it works, what's happening. One of the concerns that we have is with immigrant communities, even if you're a legal immigrant, maybe you're a little concerned, like, oh boy, the IRS is going to, be, interfacing with this insurance scheme, and maybe I want to clean up my IRS stuff before I, raise my hand for health insurance. So I think there's going to be a lot of that kind of thinking. I think a couple resources that are available to folks for more information. Certainly the Medicare Rights Center runs a national helpline, and we're out there not only through the telephone but also doing educational forums and educational working with online as well as live. But the great thing about the law is that it does fund a couple programs. One is called a Navigator program. So as of the end of this summer, because open enrollment starts in October, right? So you'll start to see ads, and you'll start to see, folks coming, working health fairs and whatnot. And many of those folks will be what are called navigators, and they're folks that are trained to enroll people in plans. And their goal is to enroll somebody in a plan. And they're not, there'll be marketing by the plans as well, but these are folks that aren't associated with the plan. They're independent. So that's one way. There'll be an 800 number that you can call. You'll be able to apply online and get information online. And the goal is to have getting health insurance be as easy as Geico or as Amazon. And I don't know, I've never bought Geico. It's probably a nightmare. But in any case, but, like buying a book on Amazon, and then not having to send it back, something like that, But really to make it very easy, very doable, but then to have there's also funding for something that the Medicare Rights Center is involved in called the Consumer Assistance Program, which is called Community Health Advocacy here in New York. And that is, once again, an 800 number to help navigate, to help figure out what are my choices, where am I going to go. So I think it's going to be confusing. It's going to be new. There's going to be a lot of resources devoted to this over the course of the next few months. Additionally, you're going to see, I think, a lot of marketing by plans. As well, to get folks engaged and involved. And one of the problems is going to be, especially for many of you that are Medicare eligible, you're used to this fall open enrollment period for Medicare. Because even if you have Medicare, every fall you get to decide whether you want to stay in traditional Medicare, you want to move to a Medicare Advantage plan, you want to switch Medicare Advantage plans, you want a new Part D prescription drug plan. All that fun stuff happens in October to December 7th for Medicare. So you have these overlapping now open enrollment periods. So I think there's a potential for confusion. There's a potential for I want a Medicare Advantage, but I saw this thing and I can get a subsidy for it. Well, no, you can't if you're over 65. You're in the Medicare program. You're not in these health insurance exchanges or health marketplaces. But I think once again, what the ACA is trying to engender here is a real seamlessness of coverage. And that, if you're younger, you may be poorer, or 58 and poorer, you can get into Medicaid. If your fortunes change, you get the better job, or you get the job, and all of a sudden you go from 130% of federal poverty to 250% of federal poverty, you call the same number, because it's the same number. It's going to be 1-800 number for Medicaid and for all other insurance. They can help you switch your Medicaid to another plan in the exchange. You go above 400% of federal poverty, you can keep that plan. You don't need to change that plan. You don't get any subsidies anymore. You turn 65, you get transitioned into Medicare. That's an issue we're thinking through, because technically under the law you can keep the policy that you buy under age 65, but you're not going to get any subsidies anymore. Mm-hmm. So folks might think, I'll keep my plan. You can't really, because Medicare becomes primary automatically. So the best course is to drop the exchange plan and just take Medicare and supplement Medicare. But there's going to be a lot of questions like that. The good news is there's going to be a plethora of 800 numbers. There's going to be a lot of online resources, and then there are going to be boots on the ground to help people. And that doesn't mean, problem solved. It just means I think there is a real effort made to, get information out there and not have anybody either fall between the cracks or, get stuck in a crack, as it were.
Yeah. At Callen-Lorde, we have one of those programs that help people enroll into Medicaid currently, and it's called Facilitated Enrollment, and we have applied to expand that into a Navigator plan, which would allow us to enroll people into both Medicaid and to these new insurance programs that are offered through the benefit exchange. And we're very hopeful that we will continue to have that designation. And we're at 15 different organizations, but we also accept people to walk in. Part of what we've done, and it's largely modeled on Medicare Rights Hotline, which, by the way, I call for questions from my mother about her Part D plan, and it's a phenomenal resource. And so we're going to copy MRC and create our own hotline where people can simply call up and ask questions, because there will be wrinkles for LGBT people. One of the things that we recognized right away is you're legally married in New York to your partner, but the DOMA doesn't allow for same-sex marriage. This is a federal program. New York State is going to work out the tax credits, because as a married couple you might qualify for greater subsidies for your health insurance. But how do you do that if you don't file joint taxes to the federal IRS? And these are things that we've worked out with New York State, and we hope that, and New York State is agreed to include that subsidy. Again, another great gesture by the state. But we will be able to help people work through some of those nuances that, might otherwise be very difficult through some of the exchanges. Again, families with children where they're legally the children of one spouse but not adopted by another spouse. I do hope that, in partnership with, again, Medicare Rights, which is so knowledgeable about the Medicare program and our own efforts, the community will be well served, and of course with SAGE and Pfizer. The one thing I want to go back and say is I'm really excited about the ACA. It's sort of like
this is as excited as he gets.
This is as excited as I get. I hear there's wine afterwards. You'll see me a little more excited. Don't get between me and the cheese, though. My nature is to look for the issues, but this is a tremendous benefit to many people. This is going to help hundreds of thousands, millions of people, but also hundreds of thousands of New Yorkers. And we should take advantage of it because it really will improve our health.
Thank you, Jay. I wanted to actually ask you a follow-up question. You mentioned, and this was actually a question I was going to ask all of you if you could speak to it, but you mentioned what we've done in terms of New York State advocacy around same-sex couples who are legally recognized in New York State. We do have people that are calling in from around the country, some of whom live in states where marriage is recognized. Do you know if there are similar advocacy efforts going on in those states?
We've partnered with a group called the American Progress Center, who is a national organization, and many of the initiatives that we've been working on in New York, the American Progress Center has been helping other community groups achieve in other states. I can't speak to the 11 other states where our folks can become legally married, or the 19 other states where people can be domestic partners. But I would be hopeful that this is something that is happening on a national level.
Can I just speak a little bit to that? I mean, at the federal level, because of course a lot of states aren't going to have their own state-based marketplace. By the way, they're now being called marketplaces. It's not exchanges anymore, but I say exchange marketplace until we, get there. So not every state is going to have one, right? And so the federal government steps into that breach, which is, it's kind of ironic that many of the states that, believe a lot in states' rights, like Texas and all, are saying, no, we're not going to set up our own state exchange, and so are ceding the authority to kind of do it to the federal government, which is a little weird, right? But in any case, for them, they will have federal exchange, and you'll be able to go on the federal exchange and buy insurance, whether you're from Texas or some other state that doesn't have an exchange. Their federal rules will apply, and DOMA will apply, of course. There's no getting around DOMA for those folks unless the Supreme Court strikes it down in the next month and a half. And their OMB, the Office of Management Budget, and others have given broad definition of family, so that policies can be offered to family, LGBT families. And then secondly, there's nothing to prevent folks from individually applying for subsidies and then combining those subsidies to buy family coverage or some other, type of non-individual coverage. So that flexibility has been, allowed on the federal exchange. So to the extent that they can kind of get around some of the DOMA related problems, they've been trying to do that, and so I think that will continue. And then, of course, if DOMA is overturned, then I think the landscape shifts dramatically with regard to the IRS and treatment of those families. But we'll still have some residual issues along the lines of the adoptive parents things, etc.
Right. Well, thank you. So I'm conscious of the fact that I want to make sure we have plenty of time for questions and answers. I do want to ask you one more question of all of you, and it's sort of a surprise question for you guys. I know you love surprise questions. It's actually a question that I've sort of reworked as I've listened to all of you, but something that we hear all the time at SAGE, and SAGE has a very large case management department of social workers and case managers who work directly with older adults, is, for those of us who aren't in a care network, and this is it can be people under 65 who are caregivers as well as people of Medicare. What is the one or two things I should think about as a consumer when I'm approaching choosing a plan? If anyone has any thoughts on that.
Sure. I mean, I think, we do this work with folks, every fall. When you get the opportunity, or when you first become eligible for Medicare, or when you, every fall, you can make a decision whether you want to be in a managed care plan, the traditional fee-for-service Medicare program, whether you want to go to a provider like Jay, et cetera. I think, there's a couple things that you want to look at when you're purchasing insurance or you're going into an insurance program. First of all, the standard advice is you want to choose a plan where your doctor is part of the plan, and you want to talk to your doctor or health center, whomever you get most of your care from. Is that a good plan for me? They're not going to sell you a plan, right? They can't say, they're not going to tell you, oh, buy plan X, right? But you can ask them, is there a plan that you feel really does great diabetic care, or really treats the kind of illness that I have, or has the right coverage guidelines and the right drug formulary, and that's a list of approved drugs, et cetera. Really talk to your trusted medical provider. If you don't have a doctor or other medical provider you're close to, then you look at the list and you say, hey, I really want to go to I really want to join the plan that has, Columbia Presbyterian in it, or has, other providers that I think of as high quality, or I know are high quality from, those kinds of things. Then you do want to look at, and this will all be standardized in the exchange, and it's standardized in the Medicare program. You do want to look at the costs. There'll be different ways that they break down costs. Though you should be able to compare apples to apples in most instances, but you want to look behind that a little bit at the fine print. So, if you take a lot of prescription drugs, for example, you're going to want to know, what's the plan's formulary? Do they have a lot of requirements like prior approval, where you have to get approval from the plan before you can get that particular prescription medication? It might be forthcoming, but between two plans that are equal, you might want to choose the plan that has no prior approval for the drug you take all the time, because you're going to be able to get it, more easily. So those are the kinds of things that we walk people through. The great thing is that in the marketplace or the exchange, there will be a kind of plan finder comparison tool that will kind of go into some of this. We have yet to see it, so we'll decide whether it's like Jay. We'll be optimistic, and then once it comes out, we'll be critical. And then because we oversample for the complainers. No one calls us up to say, hey, it's working great. Right. They call us up with the problems, and then we figure out whether those are systemic problems, and we can solve it for everybody, right? So the other thing is Medicare has Medicare Compare, which is the plan finder and tool there, and that can be of real help. But once again, we dig down, and we have some advice. We have a website called MedicareInteractive.org, where you can kind of get some of this kind of down and dirty, if you will, advice on, or the skinny on this. But it really does pay to be an informed consumer. The thing that I worry about is that folks, and this does occur, and this could occur in the exchange marketplace for folks under 65, and it occurs for over 65, and it is like, it's so confusing, there's so many plans, I don't know what to do, I'm just going to keep the plan I want, or I have now. I'm just going to keep the plan I have now because I don't want to think about this. And time again, what we see is people are staying in plans that really aren't the best deal for them. Mm-hmm. They could have a cheaper plan, they could have better coverage, but they're overwhelmed by the process. It's like, I hate to buy a new car. Who likes to, maybe some people do. I hate it, So I go into it, like, I don't want to do it. I'll just drive the other thing, or I'll lease it. That way I don't make a commitment. You really are making a commitment with your plan for that year. So it does behoove you to spend, a good day, if not more time, kind of researching this and making sure you've made the right decision and stay with it or make the switch.
I think the thing that I completely agree with everything Joe said. Just a couple of twists on it. One is I would absolutely, if you're in care with a provider, definitely ask the provider what plans they take, mm-hmm. because there will be many new plans out there, and they may not take certain plans, and they may actually begin to drop certain plans as they decide that reimbursements don't work for them. And so it's really important to communicate with your provider if you are in care. And then again, if you're not in care...
1 second, I'm sorry. Because sometimes providers are on the list, but they're not taking patients from that particular plan. So just don't depend on the paper. That's why it's important to ask. Yeah.
And they actually may have dropped out of the plan.
Right, exactly.
Still be on the list.
Right.
So you really need to call your doctor's office and be like, you still on so-and-so? I'm thinking about joining it.
Right.
The other thing is that there are going to be resources, and I think if you're someone who you need to think about your health, as Joe said, and think about how much health care you use, because on the exchange there'll be a cost calculator, and you can put in your information and decide what plan you want to buy, because it puts a lot of... The good thing about the exchange and the good thing about the Affordable Care Act is it puts a lot of power in people's hands. You can buy the insurance that you feel like going to meet your needs. You're no longer having your employer decide this is the coverage you're going to have. But you bear a lot of the cost choices as well. And so there's a cost calculator, and again, there'll be ways that either through our hotline at Callen-Lorde or other places that can walk you through it that really might make sense for you to say, I take these 5 medications on a routine basis. I have these conditions. I was thinking about a bronze plan, but I think I'm going to go for silver because, it's a little more out of pocket in the premium. At the back end, I'm going to make out better. It is tough to make those choices. You're not going to have all the information. But fortunately, you have a year to work through it, and then you can change and learn from that experience. And if you're someone who has no health coverage now, almost anything is going to be better than the out-of-pocket costs you're going to be experiencing currently. So again, I would really communicate with my provider, my doctor, if that's something that's important. If you're someone who has mental health or substance use needs and treatment needs, that's also extremely important to talk to those providers for. And these are issues of high prevalence in our community. And so think about who your providers are, talk to them, and then look at the exchange and get more advice. Talk to a navigator, get more advice.
Thank you, Jay. Raul, you have anything to add?
Yeah, our industry, the pharmaceutical industry, is relatively limited legally limited in terms of the types of dialogue that it can have with patients. It was the same issue with Medicare Part D because of anti-kickback statutes. And so, in addition to that, I think there's nothing I could really add. This has been very well covered from the patient's perspective. What I might offer is the view from the kind of the aggregate level, and a fundamental concern that I think pretty much anybody who's watching the rollout of the exchanges or marketplaces has. And it's that, as Jay said, there are enormous new powers placed into the hands of patients, and that's wonderful. But that also bears additional risks, because many patients, especially those who have not, I'm going to say individuals, not patients, many individuals who have traditionally not had health insurance, will decide, because the penalty in the first year, about $95, is relatively low, to forego insurance. Now, there are risks that individual, of course, takes by making the decision not to avail him or herself of health insurance, especially if it's subsidized, as it is for many number of individuals, but also at the aggregate level, because those are exactly the types of healthy premium payers, non-medicine consumers, that any risk pool or insurance marketplace or exchange needs in order to function properly. If it's only the very sickest, if it's only those who have no choice but to consume health care, goods and services entering into the system, then what you can imagine is that premiums will increase over time, simply because there's no one there to, let's say, balance out the risk. Health economists and probably as time goes on, more and more normal people are using the term adverse selection. and that's exactly what it is. The very last people you want entering into this financial arrangement are the first ones to do it. And again, as I said, the penalty is relatively low. We kind of equate the economics to it being cheaper to pay the parking ticket than to feed the meter, because especially if you have not been to a doctor in the past 5 years, you're young, you're healthy, the insurers call them the young invincibles, we're talking about a different patient pool than I think is represented by this organization, but they impact this organization because that is going to have upstream effects if you have these high-risk pools developing in the exchanges all over the place. Premiums will rise for everybody, and you'll have tremendous amount of volatility in the marketplace. Again, this is more of a worst-case scenario, but I do think it's something that healthcare policy analysts are watching quite closely, especially as the open enrollment period begins, and why it's so important that people do avail themselves of the services that the government's providing, and it's so important that these, so good luck in becoming the navigator, is so important for these organizations to succeed in helping the enrollment.
I mean, I think the good news is that Massachusetts has not seen, that kind of really skewed adverse selection, but that doesn't mean it couldn't occur. Massachusetts is Massachusetts.
It was almost the best case scenario.
It was the best case scenario. Yeah. You could maybe Vermont,
Right.
But so I think that is a concern and something that we'll be watching. Just one last thing, and that is you can go to the Kaiser Family Foundation, which is an operating foundation that does a lot of healthcare advocacy in Medicaid, Medicare, and now, of course, in this area, it's kff.org. And I don't know, I should have brought it with me, but they now have up on their health reform page a calculator that you can actually put in your income, and it will tell you, based upon, projections, what you would pay to get one of these policies, bronze or a silver or this or that. So, if you yourself or want to avail yourself of the marketplace, in the end of this year, or family members or whatnot, they can go there and you can kind of get an idea. I mean, there's all kinds of warning, danger, do not use this, for reality, but it's a pretty close approximation, and I think it's an interesting exercise. And so the big question will be, do these young invincibles and younger, under 30, 26, 30, 35-year-olds sign up, and do they, increase the pool? Fortunately, Massachusetts, they have, and for the most part, but it remains to be seen. So, I mean, this is going to be an ongoing story for the rest of our lives. It ain't going to ever be done.